Did you know we use the exact same medical term for a relentless, unavoidable autoimmune attack and a largely preventable metabolic condition? It is a massive medical paradox. Millions of people confuse these two every single day simply because they share a name, diabetes mellitus. But their origins? They could not be more different. What exactly is happening inside the human body to trigger the exact same diagnosis for two completely different diseases? Well, that's exactly what we're going to unpack. By the end of this explainer, you'll not only be able to spot the difference instantly, but you'll uncover the fascinating and, frankly, somewhat terrifying cellular mechanics behind both of them.
You see, the confusion really starts at the finish line. Both of these diseases end in the exact same dangerous results: high blood sugar. In a healthy body, glucose, which is really just a type of sugar, moves freely from your bloodstream into your cells to give you energy. But in diabetes, that whole process breaks down. The glucose gets locked out. And the real tragedy here is that your cells are literally starving for energy, despite having a massive overflowing supply of glucose sitting right there on their doorstep. Because this end result is the same, we group them together. But the starting points, they are completely, fundamentally different. And the sheer scale of this imbalance is absolutely staggering. When you hear the word diabetes in passing, statistically speaking, you are almost certainly hearing about type 2. Out of everyone in the world diagnosed, only about 10% have type 1. The remaining 90%, they're dealing with type 2. Keeping this stark 10 to 90 split in mind is going to be absolutely crucial as we look at how these diseases operate, especially since that rarer form is actually an unpreventable genetic strike. Now, before we look at what goes wrong, we have to establish the baseline of a healthy body. Your pancreas has these tiny little clusters of cells called the islets of Langerhans, and they produce two main hormones that act like a microscopic tug of war. On one side, we've got insulin, which is secreted by your beta cells. Insulin's entire job is to reduce blood glucose by forcing it into your muscle and fat cells for energy. On the other side of the rope is glucagon, secreted by alpha cells. Glucagon does the exact opposite. It raises your blood sugar by forcing your liver to dump new glucose into the bloodstream. When this delicate, beautiful hormonal balance is shattered, diabetes is the result.
So let's dive into path 1, type 1 diabetes, also known as the autoimmune attack. At its core, type 1 is fundamentally an autoimmune disease. Normally, your immune system's T cells defend you, and they're guided by this concept of self-tolerance to avoid attacking your own tissue. But in type 1, genetic abnormalities cause a total loss of this self-tolerance, and the T cells specifically target and destroy those insulin-producing beta cells in the pancreas. But how do they know where to attack? Well, on chromosome 6, we have the HLA system, and that codes for a protein called the major histocompatibility complex, or MHC for short. I want you to think of the MHC as a serving platter. Its main job is to present molecules to the immune system. People with type 1 diabetes often share very specific genetic clues, specifically the HLA-DR3 and HLA-DR4 genes. And these genes essentially cause that MHC's serving platter to mistakenly present the body's own beta cells as enemy targets.
The wild thing is, up to 90% of those beta cells can be destroyed before a patient even knows what's happening. But the second the insulin runs out, blood sugar spikes, and we see 4 classic symptoms. And this just brilliantly illustrates the rapid cause and effect of a body in crisis. First, the starving cells trigger polyphagia, which is an intense, constant hunger. Second, all that excess glucose in the blood spills over into the kidneys, causing glycosuria, or sugar in the urine. Third, because glucose is osmotically active, it drags water right along with it, causing polyuria, which is very frequent urination. And finally, all that lost water leaves the patient incredibly dehydrated, resulting in polydipsia, an unquenchable thirst.
If this goes untreated, type 1 leads to a terrifying, life-threatening cascade called diabetic ketoacidosis, or DKA. Because the cells are literally starving without insulin, the body panics. It starts aggressively burning fat for energy in a process called lipolysis. The liver takes this fat and turns it into ketone bodies. Now yes, these ketones provide emergency energy, but they are highly acidic. The blood becomes literally toxic. Patients will actually develop deep, labored breathing, known as Kussmaul respiration, just to try and exhale the acid as carbon dioxide. Their potassium levels swing wildly out of balance, causing hyperkalemia, and their breath takes on this distinct, sweet, almost fruity smell because acetone is actively escaping through their lungs. It is a severe, drop-everything medical emergency.
All right, let's pivot completely now to path 2, type 2 diabetes, or the resistance path. Remember that 90% statistic we talked about earlier? This is where it comes into play. If type 1 is a factory burning down so it can't make the key, type 2 is a situation where the factory is making plenty of keys, but somebody went and changed the locks on all the cell doors. We call this state insulin resistance. In type 2, the body is actively making insulin, but the tissues stubbornly refuse to respond to it.
The cells simply will not move their glucose transporters to the cell membrane to let the sugar inside. Now, we know certain lifestyle factors massively increase the risk here: obesity, lack of exercise, hypertension. Excess body fat releases fatty acids and signaling molecules called adipokines, which trigger inflammation and really drive this resistance. But I want to be clear, it's not just about lifestyle. Genetic factors play an absolutely massive independent role here. We know this for a fact because twin studies show that if one twin develops type 2 diabetes, the other twin's risk skyrockets, completely independent of their environment or their body weight.
So how does your body fight back against this resistance? Well, at first, it compensates. The beta cells in your pancreas literally grow larger and multiply to aggressively pump out extra insulin. They are essentially trying to outmuscle the resistance. But along with this extra insulin, they also pump out a protein called amylin. Over time, this amylin builds up, it clumps together right there in the pancreas. And this compensation phase, it just isn't sustainable. Eventually, those overworked beta cells suffer from total exhaustion. They shrink, they become completely dysfunctional, and they die off. And that is the exact moment when blood sugar levels truly spiral out of control.
Now, while type 2 patients usually have enough baseline insulin to avoid that highly acidic DKA we just saw in type 1, they face their own unique acute crisis, the hyperosmolar hyperglycemic state, or HHS. The crucial thing to understand here is that when blood glucose levels get unimaginably high, all that sugar in the blood acts as a powerful solute. It literally acts like a giant sponge, aggressively sucking water out of the body's cells and into the blood vessels. The cells become completely dry and shriveled. This total body dehydration massively concentrates the blood and can cause severe brain dehydration, leading to highly dangerous mental status changes.
So how do doctors catch these dangerous acute states before it's too late? Let's take a look at the diagnostic toolkit. Here, we have the 4 main standards used by the World Health Organization. You've got your snapshot tests, like the fasting glucose test, taken after 8 hours of zero food, where anything 126 milligrams per deciliter or higher signals diabetes, or a random glucose test, where 200 or higher is an instant red flag. But look right there at the bottom row, the HbA1c test. This one is brilliant because it doesn't just give you a snapshot of today. You see, when blood sugar is constantly high, glucose actually starts sticking to the hemoglobin inside your red blood cells. And because red blood cells live for quite a while, the HbA1c test reveals the average proportion of glycated hemoglobin over the past 2 to 3 months. It's basically an undeniable historical record of a patient's long-term blood sugar control.
But remember our opening paradox, how do we actually know if it's type 1 or type 2? How can a doctor tell if the pancreas is still making any insulin at all? They use a highly clever trick called the C-peptide test. When your pancreas manufactures insulin, it naturally creates a byproduct called C-peptide. They get released as a pair. Therefore, if a blood test shows that C-peptide levels are exceptionally low or completely missing, it guarantees that the pancreas is no longer producing its own insulin. And that points a giant, flashing neon arrow right at type 1 diabetes. Once that diagnosis is locked in, we have to talk about management and the long-term toll this takes on the body.
Look, this is a lifelong battle, and the strategies diverge significantly right here. For type 1, there is strictly one option: lifelong insulin therapy. The body's factory is broken, plain and simple, so the hormone must be externally supplied, usually through daily injections or an automated pump. For type 2, however, the approach is much more progressive. It very often starts with aggressive lifestyle changes, weight loss, diet adjustments, exercise, along with oral medications like metformin to help reverse that underlying insulin resistance. If those fail, type 2 patients might eventually need insulin as well. But a critical, massive warning for anyone on insulin therapy: taking insulin without eating food carries a massive risk of hypoglycemia, which is dangerously low blood sugar, and that can lead to severe weakness, seizures, and even loss of consciousness. If that blood sugar isn't rigorously controlled over the years, the long-term toll is absolutely devastating. All that excess glucose literally coats and thickens the walls of your tiny blood vessels, making them hard, stiff, and inflexible. This systemic destruction leads to atherosclerosis, causing major heart attacks and strokes. In the eyes, it causes retinopathy, leading to eventual blindness. In the kidneys, it destroys the delicate filtration system, forcing patients on dialysis. And it destroys your nerves, usually starting down in the toes and fingers, leading to a total loss of sensation. This allows small foot ulcers to grow completely unnoticed, ulcers that refuse to heal because of the poor blood supply, which tragically frequently results in amputation. And this brings us to our final, most vital takeaway for this explainer.
The true paradox of diabetes is that one single word encompasses two incredibly different realities. Type 1 is a tragic genetic lottery. It simply cannot be prevented. But type 2, the disease making up 90% of all cases worldwide, the exact one straining global healthcare systems and silently destroying vascular networks, is largely driven by factors completely within our control. By understanding the science behind it, we unlock the power to actually change the outcome. With type 2 being largely preventable through healthy lifestyle choices, the question I want to leave you with is this. Knowing the incredible, fragile, microscopic work they do for you every single second of the day, how will you protect your